Hi, everyone. Sound check. Hello, hello. Hello, hello. Hello, hello. Okay, you guys can hear me. Great. So I'll go ahead and kick us off. Good afternoon. Thanks for coming back from lunch. We're delighted to see you today. I'm Elizabeth Berard, and I am from USAID's Office of HIV/AIDS, where I sit with my esteemed colleagues working on all things priority populations. So we are glad to have you here. I'm the youth branch chief in the Office of HIV, working on DREAMS and youth participation and positive youth development and youth engagement and what else? Youth-led organizations, youth-serving organizations, you name it, youth, and that's where it all sits. So great to have you here, and I think I will go ahead and kick off, and then I'll pass it off to a number of my other esteemed colleagues from the Office of HIV, and they'll take you through some of the other areas of priority populations. How does that sound? Good. Okay, great. And I have the slide deck. So if many of you have been working in the area of PEPFAR or not, in the past, you will know that there is no specific youth stream of funding. Youth is incorporated across the board, and this is really important to remember when we're talking about, for instance, our care and treatment colleagues, and they say, but we don't have money to do youth work. Well, yes, you do, because youth are your clients, and we need to have specific services catering to the needs of all of our clients, including young people. So the same goes true with PrEP and DREAMS, as well as pediatric treatment, recognizing pediatric treatment oftentimes goes up to the age of 14. And USAID recognizes youth to be those ages 10 to 29, based on our youth and development policy. So youth is incorporated across the map, and it's really important for us to remember this. USAID recently updated our youth and development policy. It was just updated in May of this year. Very exciting. Our original youth and development policy was launched in 2012, and it was the first of its kind by a bilateral donor, but we recognized that we needed to be doing more for youth, and the needs of youth had changed over the past 10 years. So we updated this youth and development policy in just May of this year, and I'm excited to say that a couple of things are important and have changed with the youth and development policy. So these are the three new objectives around access, participation, and systems. And overall, USAID envisions a world in which young people have the agency, rights, influences, and opportunities to pursue their life goals. So that's really important to understand. But we also recognize that we need to be doing this through a variety of different ways and different objectives here. And I want to point out this youth participation objective, which is objective 2 of the policy. This really recognizes that USAID understands that the needs and perspectives of young people must be present across all USAID programming. And I say all USAID programming. In actuality, it should be in all programming, but I can speak on behalf of USAID in this case, and I'm saying all USAID programming. So in terms of thinking forward, how is it that we are actually engaging? I don't mean asking a young person to participate in a focus group, full stop. I mean, how are they involved in planning processes, in designing programs that reach them, in terms of design, in terms of monitoring and evaluation efforts? Youth should be part of all of our programs because all of our programs reach and support youth. And we need to ensure that the needs and objectives, needs and experiences, needs and perspectives of young people are part of our work. USAID recently updated, or recently actually developed, and this week has been really sharing our USAID approach to HAV and optimized programming. And of the 5 pathways, Pathway 2 is specifically devoted to adolescent and youth resilience, which is pretty awesome. The AHOP overall, that's the acronym, the AHOP, recognizes what USAID is projecting to do in terms of a sustained epidemic response broadly. And Pathway 2 gets specifically into the needs and perspectives of young people. So we are aiming for that durable, positive health outcomes for HIV-affected and, HIV-affected adolescents through leveraging of USAID resources. It recognizes that PEPFAR is one part of the puzzle and one funding stream, but USAID has a lot of other funding streams also at our fingertips in terms of opportunities to engage with our education colleagues and our democracy and governance colleagues and our economic growth colleagues. And so really thinking more proactively of how we can work together to meet the specific needs of young people. USAID's overarching approach to youth is positive youth development. How many of you have heard this term, positive youth development, before? Okay, great. So positive youth development recognizes that a young person needs to be supported in a number of ways. They need to be supported in terms of assets and agency, and that is thinking about soft skills like communication, thinking about higher order thinking skills, thinking about communication skills. They also need to be supported with hard skills like education, like schooling, like financial literacy. Additionally, we want to be supporting that enabling environment. And so that's why programs like the DREAMS program include mentoring, and they include adolescent-friendly health spaces. They include work with the providers to provide youth-responsive systems. And then additionally, contribution or youth engagement is a critical part of all of our programs. So ideally, when we look at a youth program, we're talking about all of these 4 different domains and having activities that specifically respond accordingly. And so I want to just talk a little bit about youth engagement. As I mentioned, USAID believes strongly that youth should be part of all of our programs. We're talking about 1/3 of the global population as young people, ages 10 to 29, 2.4 billion youth. That's a lot of people. And I know I'm preaching to the choir here because I know many of you are in this room for a reason. But I do think it's really important to underscore to our colleagues that may not be in this room the importance of reaching youth. They're a huge population and a huge portion of the clients that we're reaching with services or may not be reaching, but those that need services. They need to be in the room. And so there are a variety of different ways we can be engaging youth that are here on this slide, but I'm going to talk quickly about one example. In the case of one of our current contracts called Mosaic, they actually have developed a youth advisory group called the Next Gen Squad. And this Next Gen Squad is an integral part of the way the project works in general and also in terms of providing the needs and perspective, talking about the needs, perspectives, experiences of young people, integrating youth voice. So in each of the, I think there are about 10 countries, 6 countries, and I think the Next Gen Squad is 10 to 12 young people that really feed in on a regular basis into the work of Mosaic. They provide input and feedback, they review deliverables, they are a meaningful voice in the room for the Mosaic project. And they are also paid. So that's an important part in terms of the fair compensation for young people. Okay. And then this is my last slide, and this is just recognizing that the needs and perspectives of young people and what we're hearing from them is important. And we recognize that we need to do a better job of leveraging partnerships to support young people where they are. We recognize that health and HIV concerns may or may not be at the top of their list in terms of their concerns. And I see some nods. So we know that economic strengthening opportunities or education or a voice in their community, those things may be more important to young people. And so it is recognizing that we need to be looking, we have the PEPFAR portfolio, which is not going to cover it all. We need to be thinking of the family planning opportunities to link our programs to family planning. We need the economic opportunities. We need to be thinking of private sector and where private sector can come in. I don't know if our colleagues from Nweti are here today, from Mozambique. Okay. And so one of the interesting things that we'll hear, I think this afternoon actually, from Nweti is around MOUs, Memorandum of Understanding, that they have formed with small businesses and training, vocational training schools, to really be able to leverage the world outside in addition to HIV. And so I think it's important for us just to consider and think about those kinds of opportunities as well. Okay, and with that, I'm going to hand it over to my colleague, Annalise Lim.
Okay. Good afternoon, everyone. My name is Annalise Lim. I am one of the senior youth and HIV advisors in the Office of HIV at USAID headquarters. And I am also the technical lead for our USAID DREAMS portfolio. It is a large portfolio and is supported across several branches in our office. So I work with a wonderful team of people to support our countries who are implementing DREAMS. Even though my session is focused on DREAMS, I want you to know that a lot of the technical guidance I'll be sharing is applicable to any programming for adolescent girls and young women, and also youth in general. So hopefully everyone can take something away from these guidelines, even if you're not implementing DREAMS. I am curious, though, with the show of hands, how many of you are working on DREAMS programming in your country? Would you just raise your hand? Okay, great, thanks. And what about, you can keep your hand up, what if you're implementing any sort of programming for adolescent girls and young women? Okay, so we got a few more. Okay, great, thank you all, and thanks for being here today. So what I'm going to share, anyone who's worked, with DREAMS or in PEPFAR knows there is no shortage of guidance documents, right? You can dust off the book and open it up and find that section on page 399, right? So today I'll be covering a little from DREAMS guidance, a little from COP22 guidance, since we don't have COP23 guidance yet, and then also USAID specific guidance, okay? So first of all, something I wanted to highlight is what we call social assets building in DREAMS, and also how much time our AGYW, adolescent girls and young women, are spending in DREAMS, okay? So you can see I've actually put an excerpt from the DREAMS guidance because sometimes we all have a different version of how we're interpreting social assets building, okay? And so what I'd like to reinforce today is that social assets building is beyond just sitting through a curriculum session, right? Social assets building is beyond learning and practicing new skills. Social asset building also includes the social network that allows AGYW to navigate adolescence and young adulthood, okay? We know that we are reaching AGYW at a snapshot in time, right? Elizabeth talked about how we define youth, age 10 to 29 for USAID, and in DREAMS, 10 to 24. We just have a certain amount of time that is going to provide them the skills that they need to navigate adolescence and young adulthood, right? And so that's why I wanted to really talk about social assets building, to make sure that when you're looking at your program, it's not just curriculum delivery, it's not just learning and practicing new skills, but that they are also building that social network, right? Their peers, their near peers, who they can go to when they complete DREAMS and have the support they need to navigate adolescence and young adulthood. So for anyone, let me ask you this. Have any of you contributed or worked on the DREAMS layering tables? Does that sound familiar? Raise your hand if you've worked on one of those. Oh, aren't those fun? So just so you know, USAID just did an analysis across the 16 layering tables from the DREAMS OU. So thank you very much for putting work into that, because we looked at what you sent and we tried to see what is happening across our different countries, okay? So some interesting information we have as part of our revised layering table is, what is the minimum time it would take to complete the DREAMS primary package? And for those who don't know DREAMS, that is a package that every AGYW and DREAMS must receive, okay? So what is the minimum amount of time to complete it? And then what is the average time? And it was really interesting to us, right, to see these ranges from basically 2 to 14 months, right? So our question is, well, what's being done if you're 2 months versus what's being done if you're 14 months? And when we look at the age band of 10 to 14 in particular, it's going to take a lot more than 2 months to build social assets for a 10 to 14-year-old, right? So I would like to ask and challenge you today, right, when you're looking at your services for adolescent girls and young women or adolescents and youth, how long are we actively engaging them in the program? And is it enough to build their social assets? We've also shared up here the average time to complete the DREAMS total package. This definitely made us feel a little better, because even if the range was as low as 3 months, you can see that the average time is at least 11 months. Something we want to keep in mind as well, too, for those of you who also work with that infamous indicator, AGYW Prev, this is a very different indicator, right? We do not want to rush AGYW through the program to say they have completed AGYW Prev. If they sit in that indicator more than 6 months, it's totally fine. Okay? Great. So next, I wanted to highlight economic strengthening and PrEP. Many of you know that since COP20, this has been an increased focus from guidance from PEPFAR, from USAID, right, all of our implementing partners. I just want to thank everyone for this work. You can see this is the funding that has been going to PrEP and economic strengthening since COP20, and you can see that we have continued to put more funds into these critical components of DREAMS. Some of you might, actually, not everyone would have been in a session earlier, but I heard a great example from South Sudan and a private-public partnership that they started with Radisson Blue, which was really exciting to see these linkages as part of their comprehensive economic strengthening program. And then just as a reminder for those of you who are working with AGYW and that primary package of services, all 15 to 24-year-olds should have education and information about PrEP. But of course, PrEP is always offered as a secondary service based on choice and need by the AGYW. Next, we talk a lot about finding and engaging the AGYW who are most vulnerable to HIV. This is just a reminder that we should really be working across all of our technical areas to find AGYW who are most vulnerable. So those who are coming to our testing centers and test negatives, we want to make sure they're referred. For our family planning platforms, making sure that AGYW are screened and or directly referred to PrEP, to DREAMS. And then finally at the bottom is a reminder about the vulnerability and risk criteria that are used to enroll AGYW in DREAMS. Just so you know, some guidance that we are contemplating and discussing again is, do we need to look at more than one criteria for an AGYW to be in DREAMS? So many of you working in DREAMS know that guidance shifted a couple years ago. Many of you had developed ranges for your vulnerability and risk in order to enroll in AGYW and DREAMS, and then guidance changed and said, if you have one of those, you can enroll in DREAMS. Some of our teams have said this is too hard for us because every AGYW in our country is going to have at least one of those vulnerability or risk. So if that is a challenge that you're finding with your enrollment, please work with your DREAMS POCs or your headquarters support so that we can help fine-tune your screening for DREAMS. We also want to make sure that when we're doing this screening, the questions that we're asking, some of them are very sensitive and quite personal. So we want to make sure that first we are not doing any harm by how we're asking the questions and at what point we're asking the questions to determine if this AGYW should be enrolled. And then also that the level of effort and budget that it takes to screen and enroll our AGYW is appropriate, because we know that's been a challenge for some partners. Great, just a couple more slides. DREAMS mentors are critical for programming for AGYW and DREAMS. This is directly from DREAMS and COP guidance, so you all have it. I just want to reinforce some key messages that we need standardized roles and responsibilities, and we must absolutely ensure that remuneration for our mentors is in line with other either community health workers or social workers or teachers, because our mentors do it all, right? We still see some mentors who are classified as volunteers. That should not be the case. We really ask you to make sure that your cadres are aligned within the country so that we can also do a better job of looking at our cadres, ensuring that the roles and responsibilities are accurate and that they are compensated appropriately. The last thing on mentors is to make sure that there's an appropriate mentor-to-mentee relationship. We do not have the magic answer on how many that should be, right? But when you're thinking about that, and one thing we have seen is that a ratio of 1 to 12 to 15 allows a mentor to get to know the AGYW, to meet with her outside of sessions, to get to know her family, right? Because it is a mentorship, it is not solely facilitation. Great. Finally, we have a wonderful intern at our office at headquarters, and so she worked with many of you, some of you. How many of you completed or participated in the DREAMS Ambassador Survey? Would you raise your hand if you did? Okay, great, thank you. Thank you very much, because we know you are busy all of the time. We found out that we have some great practices, such as recruitment and selection, and that AGYW are always involved in selecting who will be the DREAMS ambassadors for their group. We learned that pre-service training and in-service training is highly valued and that it is being delivered across all of our countries to all of them ambassadors. You'll notice here there are some technical areas where DREAMS ambassadors expressed an interest for increased training, so we encourage you to work that into both your pre and your refresher training for your ambassadors. And then similar to mentors, really looking at the scope of work. Our DREAMS ambassadors in some countries have really evolved from what started as solely an advocacy role, and advocacy is big, even though I say solely, but now they often are recruiting or providing follow-up for AGYWs who have missed sessions. So remember again, while this is an honor to be a DREAMS ambassador, we do not want it to be cost prohibitive. Right, stipends should be provided. Depending on the scope, they might also need a remuneration package similar to mentors. I am going to skip saturation and AGYW estimates because it's all in the guidance and because that will definitely put you to sleep before the next presenter, and I don't want to do that. Thank you very much.
Good afternoon, everyone. Hope you can hear me all right. My name is Amelia Peltz. I'm the Senior Gender Advisor and the Team Lead of the Gender and Sexual Diversity Branch in the Office of HIV/AIDS at USAID. And I'm going to take you through some material, a few slides. Some of this might not be new to you. If it's not new, bear with me, but for some it might be new, or it could be a refresher too. So what I first wanted to start out by mentioning is that we're really fortunate at USAID to have a strong policy framework to advance gender equality and prevent and respond to gender-based violence. As you see on the slide here, a couple of these policies have been undergoing some revision, most notably the USA Gender Equality and Women's Empowerment Policy, and also the USG strategy to address gender-based violence. Both of these have gone through some fairly extensive revisions. I hope you'll be happy with the revisions that come out in these policies. I'm very excited. I think they provide much more expansive definitions around gender and gender identity and sexual orientation. And I think that they have really reflect a lot of the good work that you all are doing and provide a lot more scope and latitude for comprehensive programming. So those, as I said, are going through clearance and they should be released. We're hoping in December, before the end of this year, so stay tuned for that. I did also want to note around COP guidance, we're currently in COP 22 implementation. We don't anticipate having any real significant changes to COP 23 guidance. Of course, now that I've said that, who knows what's going to happen? I hope I didn't just put a hex on the whole thing. But we do anticipate that guidance will remain consistent. And if you do have any questions about the implementation of any of these policies, please feel free to reach out to me. And we have a wonderful team in Washington that can help support you with that. So this slide is a snapshot that really highlights some of the gaps and inequalities that USAID is working to close. It's been well documented that gender inequality and gender-based violence are some of the most critical barriers that we face to reach HIV epidemic control. Violence, as has been shown, it poses a substantial barrier to the effectiveness of HIV services, and it can undermine the uptake of and adherence to proven biomedical and treatment options. So this graphic helps to illustrate the vision of what USAID sees as how we want to address violence and inequality across the HIV clinical cascade and within HIV prevention as an essential part of reaching the 95-95-95 goals. So when you think about this, in the same way that we think about addressing HIV across the clinical cascade, from case identification, testing, linkage, all the way to viral suppression, the thinking about gender equality and gender-based violence across prevention and treatment, we're looking at case identification and response across the cascade, and the ultimate goal really is to improve our HIV prevention, testing, and treatment outcomes, in addition to closing these gaps in gender equality and addressing gender-based violence. So these goals very much are interrelated. We don't see them as two separate things. So putting that into practice, this is how USAID frames our gender equality and gender-based violence global strategy, and illustrates how our technical priorities are really working to reinforce all of USAID's PEPFAR programming goals writ large. So the first pillar of the strategy is really focusing on growing the program, which emphasizes the need to increase the identification, the reach, the retention across the HIV prevention and clinical cascades, both of GBV survivors, but also those who are at risk of HIV and don't know their status. The second pillar is really focused on ensuring quality and innovation within our programming in order to retain both the HIV at-risk negative individuals as well as people living with HIV, including GBV survivors. And then finally, we're putting a very strong emphasis on focusing on investments in strengthening our partnerships, particularly our local partnerships, and I'll say a bit more about that in a moment, supporting our health and social service workforces, and reducing those structural inequalities that fuel gender-based violence and harmful gender norms. So often we're asked, so if we're able to do all of this work, what would success look like? What does the world look like if we are able to achieve these goals? And so we think a lot about these short, medium, and long-term outcomes that we're trying to achieve with this integrated gender and GBV and HIV programming. So for us, what we see is it's really about reducing that risk of HIV, preventing and responding to gender-based violence, and reducing those structural gender inequalities that really do inhibit our progress towards epidemic control. So in the short term, what this looks like is we want to be looking for quarter-on-quarter growth in a couple of our key program indicators, both our MER indicators and our custom indicators, as well as increasing the use of flexible and innovative services to reach clients where they are and based upon what their needs are. Over the medium term, we're looking at sustaining the quality of our integrated GBV and HIV services that are led and delivered by our local partners, and ensuring that those services are accessible, acceptable, and appropriate for the populations that they're serving. One of the other ways to know if we're sort of on track with this strategy is we want to be looking over time at measurable shifts and improvements in gender equality and those reduced structural inequalities. And that's an important longer-term goal of the program. So one of the things that you're going to be hearing a lot about this week, you've probably been in many discussions about it, is this issue of sustainability. And this is going to look obviously very different from country to country, context to context, but we wanted to provide some overarching and guiding principles that could help inform the sustainability planning that's being done within your countries from a lens of gender equality and gender-based violence. So these strategies, we feel very strongly, it should rest on a foundation of gender equality and human rights for all. And that includes HIV and GBV services that are guided by the principles of survivor-centeredness, rights-based, trauma-informed, and gender-affirming care, and inclusive of all gender diversity. It should ensure that HIV and GBV services are accessible, acceptable, and appropriate for the people that they're serving. We also see that successful strategies will really be rooted in these community-led approaches and solutions, including the monitoring of quality and accountability. I've said it before that I really think that this epidemic it starts and ends in the community. All of the work that we're doing in the community, that's really what's going to bring around an end to this epidemic. Thank you, Lauren. So again, thinking a lot about sustainability should also be informed by our multilateral partnerships, our strategies, our normative guidance, national plans that are looking at how to codify things like ending stigma and discrimination, ending violence, really codifying gender equality and human rights in all of the planning and the work that we're doing. We're also very focused, as I said earlier, on thinking about the health and the social service workforce, ensuring it's diverse, equitable, appropriately compensated, and technically skilled. We think that having that kind of health and social service workforce and ensuring that they're provided with the necessary mental health and psychosocial support they need to do oftentimes really, really difficult work will ultimately be able to build a workforce that is strong and stable and well compensated over the long run. And finally, just to note that a good sustained plan to look at gender equality and gender-based violence, it really does rely on that data and evidence to inform policy planning and service delivery. So, okay. Unfortunately, one of my slides did not get included here, but I did want to note that I had some data I wanted to share with you, and it's showing that the vast majority of our program results for the provision of clinical care to gender-based violence survivors, the vast majority are coming from our local partners. As of around Q2 of this year, so around June, about 78% of our total services were being provided by our local partners. And so I really want to give tremendous thanks and appreciation to our local partners who are here in the room, because it's really you. You are leading the way. You are doing some of the hardest work in all of PEPFAR, and just tremendously appreciate all the efforts that you're contributing. I wanted to conclude my presentation today by addressing a really critical issue to USAID, and that's the issue of preventing sexual exploitation and abuse in our programs. Our OVC colleague Lauren, she's going to talk a little bit more, I believe, about child safeguarding, and so I'm going to focus on another aspect of that, which is the PSEA. So in 2020, USAID released its policy on protection from sexual exploitation and abuse. This is supported by USAID policy guidance in what's called the ADS, or the Automated Directive System. Really rolls right off the tongue. And it's really focused on preventing workplace sexual misconduct. There are also 3 toolkits that were created to go with the release of the policy. One is for employees at USAID. Another one is for managers, so anyone who's in any kind of management position. And there's also one for our implementing partners. Now, the overarching goals of this policy, they're twofold. The first is to prevent and address sexual exploitation and abuse within USAID's programs. And the second part is to prevent and address workplace sexual misconduct at USAID. So I wanted just to clarify, I thought it would be helpful to clarify the distinction between preventing sexual exploitation and abuse, so what this policy is addressing, and the work that we do on preventing and responding to gender-based violence. So when we talk about preventing sexual exploitation and abuse, what we're really talking about are the policies, the procedures that are in place within an organization and within its subsidiaries, so if you have any sub-partners that you're working with, to prevent exploitation and violence against those that we are serving and supporting through our programs and services. So it's really about what's happening inside of an organization. So it includes policies, it includes being able to have a system to report on allegations of sexual misconduct, and also ensuring that all staff, all employees, and all volunteers of an organization are trained on preventing harassment and sexual misconduct. The difference then from our work that we do on preventing and responding to gender-based violence is these are programs and services that are addressing violence that's occurring outside of our program. So what's happening in the community, what's happening within a household, what's happening with individuals in the community. So those are the individuals who come to our services seeking help. So it's important to make those two distinctions because we have different policies addressing both of those, but I did want to make that distinction. And just in closing, I wanted to add, so in addition to these resources on the USAID.gov website, as I mentioned, there are the policies and these toolkits for how to address preventing sexual exploitation and abuse. I've also listed a few other non-USAID, non-USG resources here that I think would also be helpful for you. And then finally, our team is looking to have more webinars and information sessions around safeguarding and PSEA, and we would really love to hear from you what would be most helpful. In terms of either information, case studies, examples. We have a lot of really practical implementation guidance we've put together so that, if you're on a site visit or if you're visiting a program and you see something and you're not sure what to do, we've pulled together some guidance that I hope will be helpful. So if you have time, either during the Q&A or perhaps even after the session, feel free to come and chat with me because we'd love to get your feedback on what you would find most helpful. And with that, I will conclude and pass it to my colleague Lauren for OVC.
Good afternoon, everyone. My colleague Elizabeth just said, do you suppose we should have everyone stand up real quick? I think they're getting groggy. Which I think everyone's a bit jet lagged and we've been doing a lot. So if you just want to stand up and shake it out or sit in your chair if you'd rather and just stretch out your arms a bit. I know that these days are long, so thank you. Hello, everyone, and a special hello to everyone who is joining online. I know that it's less than ideal to be following along. I understand you had some issues hearing in the beginning of the presentation, so thank you for being here with us. My name is Lauren Murphy, and I am a senior OVC advisor at USAID Washington. I was wondering, if you work with children, if you work in the children's sector, could you raise your hand? Keep your hands up. If you have been working in the children's sector for 5 years or less, can you put it down? If you've been working in the children's sector for 10 years or less, put it down. Wow. If you've been working in the children's sector for 15 years or less, put it down. Wow, we have a lot of expertise in this room. So I began my career really working here in South Africa for a local partner. So I know very well the expertise and experience that local partners bring to PEPFAR. And I feel a bit funny standing up here providing guidance to you, as I am acutely aware that it is perhaps you that should be providing guidance to me. And I know that what I say here today, you will bring back and you will apply it in your context and what fits with your programming. But I'm so glad to share this space with you. So, from the beginning of PEPFAR, OVC partners have identified the most vulnerable children and families in their communities. And we're here, we're lunching at this fancy Santon buffet, this fancy hotel, and they are strapping on their gumboots. They're going house to house, school to school, to bring services to those who need it most. And as we talk this week about topics like health equity, we might be reminded that it starts in our programs. How we operate, how we work with our staff, how we support our staff. And so I chose this slide to start with very deliberately, and I want to spend a little bit of time talking through it. I have lots of slides. You'll get them. I'm going to spend some time on some and skip to the others. But I think it's really important because the OVC program does not work without our valuable caseworkers. They are critical to a successful, effective OVC program. We need to support them with training materials and job aids and supportive supervision. Research conducted by Tulane University's Highly Vulnerable Children Institute here in South Africa has shown that when it comes to retention of child and youth care workers, that high quality mentorship and frequent supervision were positively associated with retention intentions among the workers. Workloads perceived as too high, or this experience of feeling threatened or unsafe on the job, were negatively associated. And so I really want us to take these kinds of things into consideration when we're working with our staff. I have 3 asks during my presentation today, and this is the first one. I want you, and a lot of you are probably doing this already. If you're not, please consider establishing debriefing sessions. It can be working with a therapist individually, it can be a group session, whatever you have. Because it is the OVC caseworkers who are going into the households, who are bearing witness to very complex issues like addiction, like IPV, and so we want to make sure that we're supporting them. And I know that you as program managers know this, but I think it's important for you to hear it from someone at USAID standing up here with a microphone. Me, my colleagues across OHA, we recognize this. And I want you to know that I will do everything I can while I have this position to make sure that we are supporting good policies and programs to support our social welfare workforce. And I invite you to find me this week if you have ideas around this. So I'm not gonna, like I said, I'm not gonna read all these slides. There's a lot of words on this slide. But this slide is basically just talking about how the OVC program has evolved from 2003. And I know some of you were around then because we'd raised hands. But in the beginning, this really was an emergency response, right? We, as advocates and folks in Congress, had to respond to the alarming rates of orphanhood and children who were becoming positive. And they will go and there's a real emphasis on identifying children in the communities and making sure that we could support them. And so they wouldn't be put in institutions, right? They would make sure that they had the services that they needed. And as the epidemic has changed, we're now really focusing on those last gaps that persist. We're highly targeted programs who are looking at our most vulnerable children and families. I'm gonna skip that one and go this one. So for those of you who have been with the OVC program for a while, you know that we have been pivoting. We've been pivoting and pivoting and pivoting. And I have great news, just like as Amelia said, that the COP22 guidance and probably COP23 guidance will stay largely the same, okay? So since COP20, we've really been working on a lot of the same concepts, right? So making sure that we have those clinical linkages, making sure that we are providing primary prevention and of HIV and sexual violence to children, girls and boys aged 10 to 14. And we're working to collaborate with DREAMS, and that's not gonna change. Keep doing what you're doing. Focus on quality of service. Do your site visits. Support your caseworkers. Again, a plug to support your caseworkers. There are two new pieces, the gender-based violence and violence against children piece in COP22, and then a behavioral health piece around mental health and psychosocial support. And I wanted to mention this because really who better to work through those than OVC, because it is OVC that is in the households, and we are, well, you are the ones, I think there's a sound issue, that are witnessing these things. Okay, so Amelia mentioned that I would be talking a little bit about child safeguarding. This is the second slide that I'm gonna spend some time on. So I wanted to highlight that, so there's a difference between child safeguarding and child protection, right? So child safeguarding is making sure that we have policies and procedures within the walls of our organizations to keep our children, as well as at-risk adolescents and adults, safe. And I want to focus on one word that's up there, the word proactive. I want us to be proactive about this. Don't wait until you have an incident in your organization. Don't wait until you're in crisis. Do this now. This is my second ask in my presentation. So I went on a site visit recently, or not recently, it was actually years ago, not recently, years ago. And we were asking, do you have a child safeguarding policy? They said, yes, we do. And they were so proud. And they brought me over to the wall. And there it was on the wall, taped up perfectly. And it said, child safeguarding policy of the government of Canada. And I wasn't in Canada, right? So we really have to think that we want to make sure that we are adapting. We're not just checking a box, that we're making sure that we're updating, and this requires vigilance. It's a constant, continuous process. When you go back, make sure that you have a policy that's in place. If you have questions about what that should look like, please reach out to your AOR. They can provide resources. Have a code of conduct in place that everyone on your staff signs. You take it, you put it in their HR folder. Next year, you check it again. Provide training to them about what child safeguarding means. Make sure that you do background checks. Have your reporting mechanisms in place, your reporting structures in place. I'd really love to see more organizations having a safeguarding POC. There was an organization who had a picture of their safeguarding POC on the wall. Hi, I'm Lauren. I'm the safeguarding POC. Here's my contact information. Let's talk. We want to make sure that we have a culture of safeguarding in our programs. This is the OVC complementary models, preventive, DREAMS, comprehensive. You know that. Click. Okay, so we have this awesome opportunity now. Ambassador Kengasong is on board, and he's looking to reimagine PEPFAR. This is a document, Reimagining PEPFAR Strategic Direction. It is easily Googleable. Go to the State Department website, you can download it. And I wanted to focus on this focus area number 2, which is children. I'm going to read it to you. Close the gaps in PMTCT, pediatric diagnosis and treatment, by meeting clients where they are with what they need through innovative models for differentiated HIV service delivery. And again, who better to do that than the OVC workers? Because we have always been doing this. Meeting people where they are, in their households, in their school, at their community center, providing differentiated HIV service delivery. What does this particular family need? Let's sit down. Let's talk about your strengths, strengths-based programming. What can you bring to the table? What can I bring to the table as my organization? Creating a case plan, right? I want to give you a quick story, quick example. I was talking with a colleague from Uganda yesterday, and as you may know, they are dealing with Ebola at the moment. And one of the OVC households experienced a loss. There was a caregiver that actually passed due to Ebola, and that caregiver left 6 children in the household. And who's going to be there for those children? The OVC program. Going to them, because they have to isolate now, right? Going to them, making sure they have what they need. And then it's not a one-off, right? They're enrolled in the program. We have a case plan. We're going and we're making sure that they're safe, stable, healthy, schooled. And there's a relationship that's formed. There's a trust there, right? And local partners are doing this. Like in Uganda, Mukobadi works with the clinical partner to conduct line listing of CLHIV in clinics to offer enrollment. In Zambia, the ECAP program brings clinical services to the community to improve viral load coverage. They're working with the clinic folks to bring phlebotomists to the households, to the OVC households. That means you don't need to miss school, you don't need to miss work, you don't need to pay for transport, you don't have to deal with stigma, you're in your home. Or in Kenya, where Nuru Yamtoto has linked DEX persons placed in the clinic to mobilize CLHIV, HIV-positive breastfeeding females and adolescents, and HEI. Oh, I'm clicking the wrong thing. Or in Tanzania, where OVC case managers join enhanced adherence counseling sessions with CLHIV who are not suppressed. And the wraparound services that we provide. This is one of the special things that OVC can do. Like in Zimbabwe, where the Muvambo Orphan Care Project provides educational support, cognitive behavioral therapy, community apprenticeship, and a whole bunch of other services that I couldn't fit on this slide. You are doing this. This is a slide that one of my colleagues made that just kind of demonstrates how the OVC program needs to have this balancing act, because there are so many different subpopulations that we need to reach. And I want to challenge you to think about the tailored services that you're giving to each of those populations. So now we are looking to enroll, for example, children of female sex workers. Well, what are the unique services that they might need? And how are we preparing our caseworkers to provide KP competent programming? I'm just gonna skip. I want to make sure there's time for questions, so I'm gonna skip through some of these. These are the benchmarks, you know these. And then this is the preventive model that I mentioned earlier. Okay, this is my third ask. Telling your story with data. Sometimes I'm in meetings and I have to explain what the OVC program does. And it would be great if I had more examples from the great work that you're doing. What would you want Ambassador Kangasong to know about your program? What would you want your community to know about your program? And the more data that we have, we can better advocate for our programming. I was recently in Kenya where they are They have a child protection information management system that goes down to the county level, and you can see the OVC in all of the counties and what their needs are. And these resources that PEPFAR has provided go beyond just OVC. They've also now reached child trafficking. They've reached the foster care system. There's delinquency and truancy, children who have or lost or not with their parents. But I'm telling you this because they were able to use this data to show the government of Kenya that, hey, we need more caseworkers. We need more children's officers. And they got 230 additional children's officers to work with their program, which is really exciting. And I know you're thinking, oh my gosh, I have so much to do, Lauren. How am I going to sit around documenting success stories? And that's when I say, you have children and youth in your programs who are so creative and so innovative, and they have ideas and they want to tell their story. And so look to them to lead you in how to do this, and work with them and mentor them about how to use quantitative and qualitative data to really show their story. And it's by having data that we're going to be able to find our place as PEPFAR moves on, as we integrate with the primary health care system, et cetera. Okay. And my last slide here is just saying that this is the most important thing that you can do. You have something that no one else has. Not USAID, not the international partners. Your expertise, your lived experiences, your community perspectives is unique to you. That is why USAID is investing in local partners. That's why we are gathered here, and that's why we are so excited about having you. And when I read work plans or procurement documents, I'm looking for the essence of that organization. What is it that you bring? Do more of that. And do it with data, so I can tell your story. Thank you so much.
Okay, great. So I think we have come to the question hour. Questions, comments, they are all welcome. I think we have about 40 minutes or so, so there's plenty of time. Is it 40? 30. Oh, okay. Our timer is off. Okay, 25 minutes. Good. Okay.
Good afternoon, good morning to those of you on the other side of the world online, and maybe good evening to those on the right side. So I just wanted to ask you a question about the OVC program. There's been a big push as of late to flesh out and be more detailed on on how the OVC program has impact on clinical outcomes, and we all know that we're trying to link it to the funding, we're trying to link it to all the different stakeholders who are looking at this PEPFAR funding and asking, how is this supporting PEPFAR? And I want to turn that question around. What about the other three domains? What about the percent of kids who were out of school who were back in school? Or the percent of kids who didn't have a birth certificate, that now have a birth certificate, and in the future could receive access to social services, whereas before they might not be able to? Are there any countries that you've worked with or that are here today that are doing that and feel like they're doing it well? Because I would love to hear your story. I will hand the mic to whoever has one. Do you have any?
Thank you so much, Daniel, for that question. And it's something that we've been struggling with. I'll just be honest. Yeah, it's something that we think about all the time, about how to better tell our story. That's why I ended with that bit there. I think that there's a lot of opportunity here. I have a colleague, Joshua Vole, who is our OVC evaluation advisor, and he's really interested on doing evaluations on just that thing. And so he's designed an evaluation agenda with some questions that we're interested in looking at. And now he's looking to talk to countries who might be interested in participating in this evaluation agenda. So this is something that we're going to be talking a lot more about. And I think also as we're moving into this new reimagining, PEPFAR, we also have a lot of opportunities to kind of explore this as well. My colleague Sarah Daster is here from the OVC branch. I saw her raise her hand, so I think she might have something brilliant to say. Not necessarily brilliant.
But no, thanks for the question. I think we recognize that the health domain has kind of eclipsed the other domains, whereas for OVC, we see holistic, comprehensive care and support for children and families as absolutely critical. Children's development isn't just segmented by domain, it's holistic. So an example, in our Tanzania OVC program, our partner there, AGYW, has documented that 80% of our caregivers are enrolled in household economic strengthening services. They are tracking the level of savings that have been generated through these savings groups, and they just reported as of Q4 that in FY22, they had generated $3.1 million in savings. This is incredible. And what we did is we advocated that in the PEPFAR Tanzania interagency space, we have agreed upon OVC program metrics. And at first, I will just say, our clinical colleagues only wanted those to be contribution to the cascade. We had to push to include savings groups, the total number of caseworkers who had been supported through the program, which in Tanzania is over 14,000. Our transition to local partners, generating domestic resources, cost sharing by the government of Tanzania. So we have to be able to tell a story that is much broader than just our contribution to the cascade. So that's just one example. It's certainly not limited to Tanzania, but I agree we in HQ can do a better job of helping to pull all of those examples together and share across countries. So thanks for the great point.
I knew it would be brilliant.
Good afternoon, everyone. Mine, I'm not sure if it's more of a comment. When we were working, when DREAMS was starting at the beginning, there were quite, we in Botswana, from Botswana, we used to have quite some things we were wondering and questioned as we were working on the DREAMS layering table and social asset building interventions. So my comment is more centered around the social asset building interventions. That do we have data that really proves that the amount or the length of time or the period that an adolescent girl and a young woman remains on the social asset building intervention actually has an impact on clinical outcomes, and not only, is it social empowerment? Yes, I hope is it a question now? Yes, yes. And if she's talking of evaluations, I think that's something that we really need to pay more attention to, because we know that the adolescent girl and young woman is a highly mobile, interested in so many things, and we have to continuously all the time be more creative in our interventions in order to secure their attention in our programs, to reduce loss to follow and stuff like that. Now, the second one is the potential, the opportunity that we really have to demonstrate our intervention, especially from OVC to DREAMS. If we do cohort-based analysis of, for example, acquisition of HIV amongst OVCs, the children that we have supported in our OVC programs who transition to DREAMS. So if we could follow our clients in cohorts over time, I think we can be able to demonstrate this, but it will be over time. That was my second. Thank you.
Thank you for that very complicated question about dreams and evidence. So I'm going to say yes, no, and maybe on different kinds of evidence or data. Evidence that showed direct impact to HIV incidence, no, for like social assets building. Evidence about how long you're in secondary school, yes, right? So depending on the component in DREAMS, we have weak, medium, high evidence, okay? For social asset buildings, some of the work that's been done, Elizabeth mentioned positive youth development when she talked about youth. And when we look at that research, it shows that a youth being involved in a program of at least 9 months or longer will have the most efficacious results. That is not a direct link to clinical outcomes, right? I'm aware of that, but we're trying to look, similar to the question about OVC, right? And saying that we need to look at DREAMS success beyond just a decrease in incidence, even though that is the ultimate outcome that we want, right? So we do have some with positive youth development that says over 9 months. There's also some evidence around mentor programs as well. Again, not a direct link to clinical outcomes, but a direct link to agency, right? And the ability to act upon your assets. We also, and I can make sure we share these as part of the conference documents, USAID has compiled all of the published literature, all of the published evaluations on DREAMS, right? Because there have been more that's been done since the inception of DREAMS, but often it's a small population or a subpopulation in a certain country, but we'll make sure and share that with you so you can see how we've been looking to measure DREAMS success. And I hope I got to the heart of your question, if you were looking at kind of how much time someone should be in DREAMS. I will also put a plug in for youthpower.org, which has several resources. There is actually a study you can see there when they looked at which soft skills or interpersonal skills have the most efficacious outcomes across health, economic strengthening, and workforce development. So that's also a great resource as far as where you should be focusing on the assets and agency parts. And sorry, I know there was a second question. Was that OV? Can you remind me of the second?
It was a comment on the opportunity. Somebody was talking about demonstration of impact on clinical outcomes, and I was saying that, you know, I see a great opportunity between, the impact, the children that are transitioning from our OVC care when they were younger, that are transitioning into DREAMS. We have the opportunity to demonstrate, with our HIV testing services, we should be able to see whether our interventions have made it possible for the young person to remain HIV negative at least for a lifetime. They are transitioning from OVC to DREAMS because they've been in our care throughout. So cohort-based follow-up of these children can help us.
Can I just, one comment on that? Is that mic on? Okay. One comment on that I know it gets a little bit challenging with USAID funding many times, recognizing our funding cycle is often a 3 to 5 year cycle, and then another project picks up. And the same with OVC and DREAMS. If you think about a child that may come into OVC care as an 8-year-old and transition over to DREAMS sometime thereafter, which is another contract. I know that there are privacy issues also in terms of sharing across projects. So not to say that it can't be done, but it can be a bit challenging. So I think that that's a good challenge for USAID to be thinking more about, because it's an excellent point. Thank you. Oh, great.
Good afternoon to all. My name is Lucia. I'm from Mozambique. I work for ANDA, and I'm technical senior of economic strengthening. I'm sorry for my English. Yes. I used to speak Portuguese. Okay, I just want to thank the presentation. I'm very excited because I only saw a woman in this presentation, and was yes, and was the unique presentation that I didn't sleep yet since yesterday. Thank you. And I don't have a question for you. I just have a little story of success of myself. And myself, I lost my father and mother with HIV. And I grew up in the rural zone until 12 age. And then I had someone, the brother of my mother, who took me to give a social assessment where I started, and I did the university. And when I left there, I was saying that one day I would like to go back to support my other colleagues, my other friends, who I saw them losing their future because they had the kids, they get married before they ended their studies. So today, I go through many NGOs, but today I'm working for local NGO in Mozambique at the place that 15 years ago I said that I would like to work one day. And and I get in UNDA. I started to work with UNDA in February. At the same year, I was promoted 3 times. Yes. So I think that God is blessing me, and I see that this program is changing lives. It's changing lives. So you are all blessed to make part of it. Thank you.
Thank you for the presentation. I didn't want to follow that. It had me thinking, what do I follow that with? But I will shoot. I am Zach Aki SI in Cameroon. I wanted to find out one of the big issues that I see we have in our own program is the issue of information data. I have a feeling, I mean, it's a personal feeling, controversial one, that we do collect a lot of information in OVC work. The caseworkers have a workload that is enormous, and they have to collect this information that is unending, which is sometimes not even correlating with the amount of data that PEPFAR is asking for, but which we know is needed for proper programming. So just wanted to find out from others, how do you balance that need for data and the workload of the caseworkers within your programs? Is routine and once-off surveys a path forward some of this information. I'm looking at issues of birth certificate, some of the services that are not routine. Do we need to start investing more in surveys, in one-off or activities that will give us some of that data, some of that information, rather than including all of them in routine data collection and make for those data collection tools to be way enormous for our caseworkers? Just want to hear from the others what experiences they have around that. Over.
Is this another question? Do you have a response? Okay.
Great question. Just from my experience in Namibia and my experience in Dominican Republic, the data's there already. They have an electronic individual level data set that that's just super rich with incredible amount of data. It's just a question of building the query. There's no need to collect more data. I completely agree with you that they're overburdened and they're collecting too much data, and probably you could cut a lot of it. But it's that one case where, oh, I'm glad I asked that question, and now we can help you with that one thing. You know, fortunately, we're not asking them to report on every single thing, because the form that they're filling out for every household is insanely large. But for the most part, I would recommend just sitting down with your OVC partner and going through their client level data set or their household level data set and seeing what is already there, and then working with that. You probably don't need to change the forms much. Would be my experience. Thank you.
I think this is a different question. Any additional comments on this? Okay. Question. Oh. Good.
A really interesting exchange with a colleague from Zambia yesterday. And she was saying something similar to what Daniel is saying, that we collect so much data. The data is there, but we have to move from collecting data to analyzing the data to using the data, right? And on that first slide that I had, it's this idea of building a culture of data use and data for decision making at every level of the program. When I was in Kenya, I visited a site, World Vision Kenya site. The subpartner is Beacon of Hope. And the OVC caseworkers showed us how they were using their data. And they put it up on the screen and they said, these are all the community caseworkers that we have. And these are the ones who, they showed what percentage of their caseload had birth certificates, for example. What percentage of their caseload was virally suppressed? And they owned this data. And they were pointing fingers at each other and say, you know, you got to pull up your socks because, you know, my caseload has, you know, this and this and this, and what are you doing? And it's this working with each other every day to understand where the gaps are in the programming. And it's just working to really use the data, not just collect it. And I don't think you're alone, Zach, in Cameroon. I think a lot of people are struggling with this. So thanks for that question.
Sorry, one more quick comment on your thing. Just so you know, we had $120,000 set aside for SRE. So we decided to draft almost like a draft solicitation asking a contractor to draft a protocol. And what it would do is essentially that we would hire a contractor to go work with our OVC partner and help them transform their data information system into something that can routinely track OVC benchmarks across the 4 domains. Not only for their entire cohort, but then also to one of the things that money would be used would be to do a prospective analysis of all, so for future cohorts. So of those who start this quarter, where are they in 1 year? For those who start in the second quarter, where are they after 12 months? To track those indicators and see progress over time, so that if we can't match clinical outcomes to the OVC program, which frankly we shouldn't even have to do, but let's not go there. We should still be able to show the other areas where we're supporting, so that if, for example, the clinical program is so strong that there is no measured impact of the OVC program, then you can show the measured impact on education, economic support, stability, security, all those domains, and really not only fine-tune your program, but sell it to the different stakeholders that are trying to figure out how to spend the COP money, et cetera, et cetera.
It's a great, just
Share that.
two other quick comments on that. I think one of them is we recognize that PEPFAR is a very data-heavy program, and sometimes we kind of get caught up in thinking about how do we feed the indicators that PEPFAR wants, that PEPFAR wants versus what is the data that we need to actually help with the case management and do that. So if you're thinking about that kind of balance of time, and as we move towards this idea of sustainability, should we be putting more of our LOE onto those, data collections and data analysis and use that really helps to show those longer term outcomes, or what's really going to feed into more sustainable systems? Yes, of course, we still have to report on the MER indicators, but when you're thinking of the balance between those, that could also be something to consider. Maybe you didn't hear that from me. I'm not saying don't report on PEPFAR indicators. I'm just saying, thinking about the LOE. One other example of that, in terms of that data collection, there was a great example, and I don't know if my South African colleagues are here, but we had a really interesting analysis we did, the South Africa team did, using GIS data, existing data. And they looked at TX Cur, so the PEPFAR indicator TX Cur, and they overlaid it using GIS data with hotspot data on cases of gender-based violence. And they drew that from existing data sources from the South African Police Service. And what was so remarkable about this analysis was it showed that the areas, the clinics that had poorer TX Cur results were also the same areas that were GBV hotspots, where they were seeing a lot of cases of GBV. And so that analysis was incredibly compelling, even though it was not necessarily new data, or it was existing data, but it really helped to draw that link again between experiencing violence and the difficulty in retaining oneself within ART. So even analyses like that could be quite compelling when you think about resource allocation and where do we need to be seeing our programs working together for those outcomes. Oh, okay, I see, oh gosh. Oh, I think we're at a time, right? Okay. But so I think, unfortunately, sorry, we are at time, but we are able to stay behind and answer a few more questions. But just want to thank all of our presenters today, and most importantly, thank all of you for being here, for your engagement, for your questions, but most importantly, thank you so much for the hard work that you're doing. You're doing the real work every single day. We're just sitting up here and talking about your program examples, but they're really yours. And so all the appreciation and recognition really goes to all of you. So thank you so much.